Interesting.
All right.
Would you agree, Riggs?
Oh, that was crazy. That poor woman.
Yeah. We had a lady come in. Now, she's like 33. She has Crohn's disease. Her med history is otherwise uneventful. Um, we just started ortho on her, upper expander, lower trays. About last Thursday, out of nowhere, her mouth just feels like it's completely on fire. And the last 3 days, she's only slept about 5 hours. Said she drank 12 bottles of water last night, and she hasn't stopped drinking water since because it's the only thing that helps her feel better. She doesn't think it, I don't think it had anything to do with the ortho. I just think maybe, timing is odd. But there's no ulcers, no lesions, no redness, no swelling, nothing in her mouth to indicate there's any actual problem, except when you touch the tissues in her mouth, she feels like she's on fire and it's tender to touch. And it's everywhere. It's her tongue, it's the buccal tissue, it's the roof of her mouth. It's mostly toward the anterior portion of the roof of her mouth.
Bilateral?
Huh?
Bilateral?
Oh, that's the best.
Lateral. Yeah.
Yeah.
Yeah. And so, questions, went through my mind. The reason I talked, does she have a fungal infection we can't see? I've never had someone come with a fungal infection that caused them to like be in that much pain though, all of a sudden out of nowhere. She doesn't have, other than Crohn's being her, autoimmune disease. She has no, she takes Humira for that, but she's not like, she doesn't have asthma. She's not using inhaler. She's not doing anything funky. She started using a new whitening toothpaste. Maybe that's part of the mix. Ultimately, we gave her a dexamethasone mouth rinse to see if that can reduce some of the inflammation she's feeling. I did numb her up with Lido, did an eye on either side, and basically a nasal palatine injection, and all of her pain went away. Um, but I don't know. But she
After,
had bad mouthwash, and that made it worse. They gave her that at Quick Care.
so you gave her 2 IANs and a nasopalatine?
Yeah, and all of her pain disappeared.
What was the sequence? Did you give her the 2 IANs and then she was still in pain?
Oh,
Yeah, I gave her the two INs, and the INs got rid of everything that was burning in her tongue. And oddly enough, all the sensation of burning on her upper buccal tissue went away too. But I didn't numb anything up there. And then after that, the only place still bothering her was the roof of her mouth, and it was mostly in the anterior. So that's where I did that nasal palatine. And after that, you just physically saw her, kind of like when I adjusted your tooth that day. You just like that was her reaction. Yeah,
Euphoria.
that was it.
Wow. I'm going to call you the pain whisperer.
Great.
That's awesome,
Well,
man.
Regan helped me at least get that far because we both were like I hadn't looked because the rest of you guys know this, but I'm colorblind. But Regan, and I want him
hi.
to make sure I'm not missing anything, like nothing's red that I don't see or something else. So he didn't see anything either. So we're like, shit.
Wow. That's definitely going to require some oral pathology deep dive. I mean,
Yeah,
obviously, when it's bilateral, we tend to rule out localized pathology, um, neurology. You
yeah,
know,
we
you
could
know,
be
I
nerves.
SLS comes to mind as something that might cause this kind of thing. You say she's on a new whitening toothpaste.
Yeah, but
Um,
she stopped. We told her to stop using.
yeah. Well, keep us posted. I think this. I think oral pathology should be something we talk about regularly. Um, I like in JADA they often have a case. Well, they always have a case report at the end of the monthly publication. You just don't see things often enough. So I think it's great that we're talking about it. Does anybody have any other thoughts? I mean, my head when it's bilateral always goes to something the patient's using, some sort of external um, erosive component. Those two locations seem a little bit odd that they're connected. Um, I definitely don't think it's nerves because those two areas obviously have different nerve
Yeah,
distributions. It
yeah.
doesn't sound like trigeminal neuralgia. Doesn't sound like burning mouth. Um,
It'd be weird if it were either one of those.
yeah. Was she intubated recently?
No.
Well, keep us posted. What was the exact prescription for those in the group that aren't comfortable with prescribing steroids? Can you kind of give us your line of reasoning?
Reed, you have to jump in on that one. I know we talked about it briefly, but you were the one who really strong armed that side of it.
Yeah, we did dexamethasone, 0.5 milligrams per 5 ml. I had her doing it 4 times a day, so I dispensed a little bit more than whatever that math works out to be.
So that's
we want to reduce that inflammation.
So a topical elixir?
An elixir specifically, yeah, elixir.
And she
They didn't have an elixir; they only had solutions.
Reagan, why that one over like that Kenalog one that we did for that one lady last week?
Kenalog is like a first line defense for the more mild versions. So I went right to the moderate as opposed to like the severe option. I talked to her briefly about any dermatologic conditions that she may have, and if she had a dermatologist she could contact just in case we realize it is fungal. One question I did have for Luke when we were just privately talking was, when is the moment to take a culture? Because I feel like today probably was that day. I'm pretty unfamiliar with that process, but it was a good conversation we had.
Yeah, not sure.
Yeah, and when do we refer? That's always a important question. Obviously, you triaged her, and I think what you did works well. And if the steroid rinse helps, obviously buying some time. But if she's not any better, do we have any other tools in the toolbox, or should we refer at that point? Let's say she shows up tomorrow and she doesn't have any resolution.
I mean, we could try ruling out fungal, but that would, yeah, that's all. Not impossible, but it seems like a lot of pain for someone in fungal. Have you ever had someone?
Yeah, but
no physical symptoms.
So the fungal doesn't cause the pain; it's the inflammation in response to it. So you would assume that the elixir would help.
Would you see something? I mean, if she was in that much anguish, you would think you would see something, and we couldn't see anything.
Yeah. I can't think of a moment where I saw something or assumed something was fungal and I didn't see anything. There's always the backdrop of autoimmune conditions that reach the point at which they become clinically relevant. This seems like a pretty significant, first presentation for something like that. Typically, it comes on more slowly. And if it gets severe, it takes years to get there.
Could her Crohn's disease have some sort of weird effect here? I mean, that seems off, I know, because that's really more the lower region of things. But
well, whenever you hear a patient that has an autoimmune condition, you have to always assume they have other autoimmune conditions. They tend to occur with each other. There is a correlation with Crohn's disease and the rest of the GI tract, including the oral cavity. But this presentation just sounds odd. Somebody was chiming in there.
I think it was Reed's son.
Yeah. Ollie, do you want to provide a differential for us?
Sorry, I missed the beginning of that. Did you say that you recently put them into some sort of ortho treatment?
Yeah, we're doing an upper removal expander and lower Invisalign, and we'll swap over to all Invisalign after the expansion process is done.
And I don't have the experience with it, but I'm assuming it's pretty rare to have some sort of reaction to different metallurgies used in ortho.
I've never had anyone have that kind of issue. I mean, she could, but usually something like that would be more isolated to where the metal itself was touching. Most of what we're doing is plastic or acrylic. There's not a whole lot of metal parked in the areas where she's, experiencing that discomfort and pain.
Cool. And then a follow-up question, just with the local that you gave her, what did you decide to use for anesthetic?
I just ended up using Lido. I thought I could use Marcaine maybe, but I just wanted to get something in there that, you have to fiddle with too much.
Cool.
When did you start ortho treatment? I guess I missed the beginning of that.
We started ortho. We gave her I started trays a few weeks back, and sometime at the beginning of last week, it was like Monday or Tuesday, we gave her expander.
Okay.
Thursdays when she developed this sudden burning all throughout her mouth.
Okay. Thank you, John, for bringing that up. I missed that.
Yeah.
That connection. You are right in the fact that you would typically see an isolated area.
Yeah.
But if they're allergic to either methacrylate, which is part of the Invisalign trays, or nickel being the primary component of the alloy in the metal inside the expander,
Yep.
I definitely think that's what it is.
Oh, that'd be interesting.
Yeah.
I mean, she hasn't been wearing anything for the last few days. She stopped wearing everything on Thursday when it started, and nothing's resolved.
Right.
I don't know how long it would take to calm down.
It could be a combination of the toothpaste and the appliances. This interactions with the dentrifices, if that's a word I can use, and appliances. There's chemistry occurring. Whatever ions or free radicals or compounds that are produced interact with the tissue. If it's a sensitive patient, you could definitely have something. I've had patients over the years who have developed metal sensitivities with a crown they've had for 30 years. So it's not just when you place the crown. People can develop allergies at later points in life. Our bodies are always going through changes, so it's not uncommon to see that. How old is the patient?
Like in her early 30s.
Yeah. Yeah, I think it might be good to have her refrain from wearing the appliances and then maybe reintroduce the methacrylate component first and then reintroduce the metal and see if...
Which one or the other.
Yeah.
Yeah, because she was already wearing the trays for a couple weeks with no problem. We just gave her the expander.
So if you had to say, it was probably the expander.
Expander was the one thing that was recently changed.
Yeah.
But I thought maybe not the expander after really the buccal tissue on upper and lower was bothering her. That seemed weird to me to make that the expander. But like you said, I told her not to wear anything for the next few days and touch base with us Thursday, Friday, and see how she's doing.
Right. Hey. Sometimes we have to try. I mean, I hate these kinds of approaches where we're just trying different things, but medicine's really good at it. Why can't dentists do that too? Sometimes.
Oh, we don't always have all the answers, unfortunately.
That's right. Anybody else have any questions, contributions? All right. So I'm going to switch over to my screen. I'd ask Labonte to tell me when I switch over if my screen is showing, but the past 3 weeks he hasn't been there.
We can see it.
He typically falls asleep around this time.
It's there. I always reply. I know my job.
Stay in your lane, bro. All right. So this is in an alternate universe, this is what I look like, much more handsome than the current universe. Where do I go to show the slideshow? I'll just go one at a time. All right. So we went over this last week. I'm going to quickly bring everybody up to speed on where we were. This made more sense with the slideshow. Does anybody see where? There we go. All right. So last Saturday, we're going to call that day 1. So that would be 9 days ago. I started by having pain in the area of number 31. I would describe it as something along the lines of a dull, severe achy pain. It's not too often that patients describe dull and severe in the same sentence, but that's definitely what I was experiencing. So it was kind of hard to elucidate whether I thought it was something tooth odontogenic related, which tends to present as severe pain, versus something more periapical or something associated with the surrounding tissues, which more often than not presents as a dull ache. I kind of had both. Relevant medical history. I have sleep apnea, mild sleep apnea, and generalized anxiety. I take a small amount of medication for the anxiety, which I'm currently weaning off, so I don't really think there's any sort of contributory thing here. With that said, the sleep apnea is always potentially relevant. I had a shoulder operation 10 days prior to day 1. So at this point in time, I can't help but think it has something to do with that. Can somebody say if they can see this?
Yep, we can see it.
Perfect. I think somebody's potentially joining. Let me X out of here for a second. All right. So this is an iTero scan of my jaw before. This was taken in the fall. And here's the tooth that I ultimately started to feel the symptoms on. You know, this redness in this area is not something of any significance. Again, this was taken before. What you can't appreciate here is how large my tori are. I have very, very large tori. Let's just say the lingual concavity comes down to about this area here. So if you were to take maybe a perio probe and come around and go apical along the lingual tissue here, you would end up this far down because there's that much of a concavity, and we'll see that on my CAT scan. And here we have a picture of my mouth. You can see the tori here. But I don't have any biomechanical issues. I'm not a grinder. As you can see, my cusps are relatively intact. For those who are entering the dental profession, I think it's always good to get a general sense of patients' potential parafunctional habits. Where I was trained, we were taught what bruxism was, but we weren't really taught how to kind of put patients into different categories based upon that. And I think it's super helpful to do that. All right, so day 2, we had obtained a CAT scan. This was when Luke met me at the office on Sunday. We didn't find any signs of odontogenic origin. There was no decay, no periapical radiolucency, cracked teeth. He did the endo testing, which was relatively normal. Yes, number 31 was a little bit exaggerated, but it did not reproduce the symptoms, and that's very important. When we're doing endo testing, our goal is to reproduce the symptoms that the patient's complaining about. All too often, what we do is we do a bunch of endo testing, and then we try to come up with a diagnosis, and we forget the fact that our ultimate goal is to have our clinical scenario match their personal scenario before they came in the office. So at this point, we're not really seeing anything. Luke did look on the lingual. He saw some red tissue, looked inflamed, but at this point, you know, I'm telling him it's a toothache. So, you know, we're thinking that this is of odontogenic origin. So he adjusted the occlusion, and I felt much better. I wouldn't say the pain went away, but I definitely felt like I had my bite back, and that did provide quite a bit of relief. He didn't numb me at that point. I didn't really need any numbing when he adjusted, but I went home that night feeling like, okay, now that the occlusion's good, we're better off. So here's the CAT scan, and this is a video of me talking about it. So I'm going to go ahead and start it here. Hey guys, this is my clinical CAT scan following up on the vignette I'm tentatively calling Nick's toothache. So again, it was tooth number 31. This was the CAT scan taken the day after I started noticing some discomfort in the tooth. We went over this in one of our treatment planning sessions, but I wanted to go over it again because I have more information at this point. But let's just review what I noticed on day 2. Just severe toothache, more of a severe dull ache than a severe jabbing pain like you would notice with a tooth that is undergoing irreversible pulpitis. Although, in retrospect, it was really hard to tell. All I could say is it was severe. It wasn't just a nuisance. So here we have the lingual concavity, and we had talked about the fact that this periodontal pocket was present. I do brush my teeth and floss regularly. With that said, this torus that you're seeing here, I have very pronounced tori, is unfortunately invading biologic width. So I think long term I have a chronic perio pocket here that hasn't broken down to the point where it's been inflamed and been picked up during cleanings, but at some point this is likely to be contributory. So that's one area of potential contribution to my symptoms. Obviously, the shoulder operation I had 10 days before, I think, may or may not have had something to do with this. My original assumption was the following. All right, so we're looking at this image here. You can see, let me just start on the mesial root so you get a full sense of the tooth from this axial slice. So there's the mesial root system. Really nothing significant there, no decay in the tooth. I don't have any parafunction, so I wouldn't think there's any cracks. Then here's our distal root. And as we noted during our treatment planning session, I made the point that sometimes teeth in this area actually exist a little bit outside of the cortical bone. This is why, I'm going to take a small little tangent, but I think it's important. This is why it's important when we extract teeth. If we put too much buccal force or force in a buccal direction, there's going to be a reciprocating lingual force. One of the reasons why patients sometimes end up with bony sequestra in this area has to do with the fact that when we rotate the tooth out, we potentially fracture the lingual plate here, and then a bony spur gives way, and this thin mucosal tissue that's overlying this area eventually gets irritated by that bony island, and I have seen several of these over my career from teeth I've extracted and others have extracted. So I'd say it's a normal sequelae of dental extractions. With that said, I think it's a good reason that we use our sectioning techniques to remove teeth without a buccal lingual force of extraction. With that said, that's a topic for another day. The point is that sometimes the teeth live outside the alveolar housing, and this bone in this area, if injured, can exfoliate and irritate the tissue, and the patients can have pain at a point somewhat far away from the initial treatment. I'm talking weeks and months after an extraction, or in my case, a supposed injury from intubation. So my thought was at this point in time that they had intubated me and they had, irritated the mucosal lining, and because the tooth had almost like a communication through the cortical bone, that the inflammation associated with the mucosal lining caused my tooth to rise up, which was true because Dr. Libby adjusted the tooth on this Sunday, which is day 2, and it felt much better. So at that point, I went home thinking that's all it was. My hope was that the pulp inside the tooth wasn't affected to the point that I needed a root canal. He had definitely adjusted it to the point where I felt like it was no longer touching. So that's the end of my experience on day 2. I'm going to continue my PowerPoint presentation, and I will come back with another video with another CAT scan. Awesome. All right. So Monday comes around, and I'm still in pain, but I'm thinking to myself, well, maybe I had reversible pulpitis in the tooth, and the area is inflamed. It's just going to take a little bit of time. Day 3 comes around, and it's kind of worse. And I'm going to see the Bruins that night, and the last thing I want to do is go to a Bruins game with a toothache. So I came in the office, and Dr. McDreamy, also known as Dr. Zachary Regan, did a pulpotomy on me. Let's just take a quick moment and think about that for a second. I asked him to do this. He wanted to do a pulpectomy on me. I'm in a lot of pain. I'm late for the Bruins game. He's seeing me in between patients. I don't want to be more of a nuisance than I really need to be. I'm going to say the following. When you have adults, and this has been proven in the endodontic literature, I can't say whether or not it was the right decision for me. I think in hindsight, I don't think it mattered because you'll see it in a little bit. Doing an adult pulpotomy for patients that are in severe pain. It's not necessarily called the, what do they call that? The Czech CVEK pulpotomy that we do on kids. If you decide to do that, if you're ever trying to get a patient out of pain and you remove the pulpal tissue, if the stumps from the canals are not bleeding, you can safely assume that the canal nerve tissue is not irritated to the point that it will have any issues in the interim. I just want to let that sit for a little bit, because when I told Zach this, he was like, no, you got to do a full pulpectomy, and that is how we're taught. So I don't want to say that he was wrong or anybody else is wrong. I was taught this by an endodontist, and I can tell you I've done it many times and it's worked fine. Unfortunately, it didn't work for me, and you'll see why in a little bit. But if you're ever running behind and you have a patient and their pulpal irritation, their irreversible pulpitis, is isolated to the pulpal tissue, and that is the case early in the progress from reversible to irreversible to something periapical. Let's just say that I was confident with him doing that because the CAT scan didn't show any periapical issues. So I was assuming that the inflammation hadn't made its way down the root. This came on very quickly, so my thought was, let's just get out the coronal tissue, or the pulpal tissue in the chamber. So later that night, still in pain. What hurt even more was the Bruins lost. So the rest of the week goes by, and I'm not on antibiotics yet. I didn't think of this as a biological process. I really felt like this was something to do with the intubation, and I didn't feel like an antibiotic at this point was necessary. Motrin and Tylenol were great for about 4 hours, and then those last 2 hours before I could take another dose, the pain would start to ramp up. Dr. Labonte was so kind. As you can see, I threw the kitchen sink of associates at this. Basically, everybody in the office has stabbed me in the past week, most of them with much grin on their face. Dr. Labonte finished the root canal. So my thought was, okay, Zach was right. You can never do a pulpotomy in an adult. I should know better. I should have listened to the doctor and not listened to the patient. I still stand by, now that I know what happened, I stand by the fact that you can do this in some patients. But Dr. Labonte did a great job. He brought the canals to a size 15 to their working length, so he fully debrided the canal system. Anesthesia wore off, and I'm back to the original pain. So that was Friday, so 3 days ago. So what are everyone's thoughts at this point? So nerve inside the tooth is completely gone. The pain is isolated to the lingual tissue of number 31. Ibuprofen and Tylenol every 6 hours brings the pain from a 9 to a 3 fairly predictably. And all the other teeth in the quadrant are normal. I say they're normal. They were definitely somewhat sensitized, but anytime you have a tooth in a quadrant, at least on the lower, because the nerve is so profoundly connected to all of the teeth, it's not uncommon to have sensitization of the other teeth. And that's something you always want to remember, that teeth next to teeth that are the primary culprit will also exhibit heightened clinical signs. So what are everyone's thoughts at this point? Should I go on antibiotics? Let's say this is Friday night. Everything I've shared with you is the information we have. What do we do?
Well, I
Did
guess
the
the
tooth
question
need a root
would be,
canal?
sorry, Ryan, you go.
Did the tooth need a root canal? Like, what was the diagnosis?
So when, in hindsight, Luke, do you want to, because Luke, you were the one that really did the endodontic testing. Did you get the sense it needed a root canal?
Day of we were there, no. Technically, from one of the shots when we did look at Dr. Roy's tooth from the panoramic perspective and then slicing through it from the buccolingual direction, there was evidence of periapical radiolucency on the roots, but it wasn't astounding. It wasn't enough that either one of us was like super convinced he needed endo. And then testing his tooth, it did test vital, and obviously it was percussion sensitive. So it was one of those like, is it dying and it's just not there yet? It's just alive. He wasn't flipping out in the chair when I hit him with the ice.
So based on that, we shouldn't do endo, correct? I mean, that Luke was willing to do the endo on that beautiful Sunday afternoon, bless his soul. But because of the endodontic testing, I'm a huge proponent of not doing endo on teeth unless there's a reason to. I know we all agree on that, but we get in the trenches of everyday dentistry, and it's easy to just send the patient down that road. And we've gone over that as a group of doctors in the past on, especially during our NECADE session in the fall. We talked a lot about diagnosis, proper diagnosis, and what have you. The reason why I had Zach do that on Tuesday was because the pain was spontaneous. So when you have a tooth that tests normal, but the only problem is spontaneous pain, do you treat it? And that's a age-old question in dentistry. There's no right. I can promise you, there's no right answer. Does anybody want to share their, what they were taught, or what their perspective is under those conditions?
Was it like
Did we
pulpal?
test
Was
you that day,
spontaneous?
did
Go ahead, Dr. Stalker.
So was it spontaneous, like from the tooth? Like you keep talking about the tissue was hurting you, right?
Yeah, I mean,
Like was it pulpal? Was it, was it pulpal sensitivity?
Well, I think it's a good question. You would think as a dentist I could answer that. When the pain reaches that level, it's impossible to tell what's going on. Even though I thought that it was the intubation, I still felt like it was the tooth. Now, there's one other complicating factor here. Anybody want to take a stab at where I was also hurting? And I didn't bring this up yet.
Was it where your tori were?
So I definitely have pain where my torus is. That's where the lingual inflammation was located.
Your shoulder?
Yeah, I mean, that's a good question in the fact that my shoulder felt better on Saturday when this all started. So I'm wondering if, I don't think it's related to where my head's at right now with it, but I do think it's an interesting question to ask, that when patients have pain in two areas of the body, do they not notice one? They take, the brain focuses on the one that's more significant. We talked about protective co-contraction last week. Anybody want to take a hint? What muscle likely was inflamed because of protective co-contraction? Masseter. So protective co-contraction is essentially the following. If you had a pebble in your shoe and your calf went into spasm, that's protective co-contraction. It's essentially the muscle is being asked to do something that it doesn't like to do. In this case, the masseter didn't like the fact that my lower, or number 31, was in pain. It goes into a contracted state. Now you think it would kind of relax because it's an elevator muscle, but this is how this works. It has to do with the central nervous system being overloaded. My masseter was definitely part of it, and my temporalis. I had a trigger point here, and if I massaged it, my pain went away, and then I let go and the pain would come back, and then same right here. And both of those locations I could feel tight muscle bands. So there was a myofascial pain disorder condition component to this that you'll see with patients in pain. Tooth pain does elicit muscle responses. The hard part is we see this in patients that don't have toothaches. They just have a prematurity, and then they have pain. They think it's the tooth, but it's actually the muscle. So always remember the muscle might be part of it. It might be in conjunction with, or it might actually be the reason there is a toothache. In this case here, it was in addition to. So like Elena was saying, that torus is really where I think the pain was coming from now. But at this point, the only thing that we saw up to this point was Luke said the area was red. But we see redness around the tissue of teeth that have periapical pathology all of the time. So at this point, I don't really see any reason to think that it's anything other than my original theory that innovation caused the tooth to rise up and what have you. So at this point, there's no nerve inside the tooth. I'm at a loss at this point. I could have put an aqualizer in, but because I had irritation of the lingual tissue, I didn't think it was a primary muscle issue. So for those who are unfamiliar with the aqualizer is a triage and diagnostic tool that we can give our patients that have TMD issues, and it works really well for acute myofascial pain disorder. So patients come in with a trigger point in their masseter for a multitude of reasons. You give them the aqualizer and they get better. But I knew because I could feel it with my tongue down on the lingual that it wasn't necessarily muscular. So I didn't really feel like that was the right solution. So let's fast forward to Saturday morning. I'm kind of at the point now where I'm like, I got to go in and put a probe in my own mouth. Okay, guys, welcome back. So this was on day 7. Saturday morning, I have nothing else to do. 2 kids at home, a wife that needs help. But I got a toothache, so I'm going to go in the office and I'm going to try to troubleshoot this myself. Granted, the entire week I was trying to figure out what the heck was going on. So up to this point, my thought was, like we talked about earlier, irritation of the mucosa from the intubation, rising up of the tooth, causing pulpitis. I really didn't think that it was irreversible pulpitis, but honestly, when you're in that much pain, you're going to ignore this. Well, I guess that's why doctors shouldn't treat themselves. Anyways, I had the help of some really good doctors, and we all came to the same conclusion. Pulpectomy is what was needed. I mean, it really was screaming spontaneous pain, waking me up at night. Ibuprofen was helping. So as you can see, the pulpectomy was completed the day before this image was taken. You can see the calcium hydroxide that's in there. The nerve was completely removed. Working lengths were achieved, brought to a number 15 file. For all intents and purposes, if the pain was coming from the inside of the tooth, one would think that the pain would have changed after the root canal. Unfortunately, after the anesthetic wore off, the pain came back. So literally, the entire time, we're focusing on odontogenic etiologies. At this point, I'm starting to think it's something with the PDL. And I kind of had that thought initially because of the fact that this root tip on certain images does poke through the lingual plate. So I thought the PDL inflammation induced by the intubation was a potential source of it. So I went into the office and I got I'm in a mirror. I got a perio probe down here and I'm measuring, there's a good 9mm pocket here. Now keep in mind, this whole area is inflamed. So is it 9mm or is it a 9mm pocket composed of a pseudo pocket component, meaning the inflamed tissue was giving me a reading that was somewhat false. With that said, when this is all said and done, I'm going to have one of the doctors basically remove this. We need more crown height anyways for the crown that needs to go on this. This torus is just causing issues. Matter of fact, I might have whoever the doctor is do an entire removal of the tori. I have airway problems, and I have no doubt it's because I have so much bone pushing my tongue out of the oral vault. With that said, I need to get this resolved first. So, it's not coming from inside the nerve. Everything I've had done up to this point, after the anesthetic wore off, was painful. So I take a probe, I'm probing down here, and it's bleeding a little bit, not too bad. The pain's not really replicating the pain I have when I'm kind of waning off of the ibuprofen. But then I take the probe, and this area right here is what hurts. So I take the probe, I feel over here. This is tender, but in hindsight, it's only tender because this is tender. This is just kind of the innocent bystander. The pain's coming from right here. So I take the probe and I'm coming down, and all of a sudden I feel a piece of bone here. And I'm like, you've got to be kidding me. I have a bony sequestra, which in the back of my mind I was thinking could be a possibility down the road because I've seen that before. And we've had a couple patients in the office who had intubation for general anesthesia that came to the office with similar situations. But let's just take a look at right there. So that wasn't there before. I'm going to turn the video off because the kids are home. But let's just make a note of that. I don't have the images back to back, but I can tell you that there is more radiolucency here than there was on the CAT scan I took a week before. So I get in the chair and I take an image, and this is what I see. So this is on Saturday. Dr. Hicks is up to the plate to help out, and we noticed that this is actually bone. So if you take the probe, when I took the probe and I put it down here, I could actually feel bone. I thought it was maybe a sequestra. It wasn't. This is actually exposed. This whole area right here is where the pain's coming from. As you can see, there's so much inflammation here that the tooth looks completely, I mean, Dr. Regan mildly dropped that out of occlusion, and you can see how far down it is. There's a lot of enamel left there. So he didn't take it down that much. It just looks that way. So ultimately, I need some crown lengthening around this tooth anyways for long-term periodontal health. I think that probably should have happened before, but typically it takes something like this to happen. But as you can see here, there's this laceration, and it's pretty far down there and it's pretty far back. Dr. Hicks, do you want to shed some light on how far back in the mouth this is? This picture doesn't do it justice.
Yeah, no, it was, it seemed like it was almost just below the crest of, the thickest part of that torus. Yeah, it was far down.
Yeah. You didn't say it, but I think you were thinking next time you have a toothache, can it be number 8 facial?
Yeah.
All right. Anybody know what that is? It's a Miller number 3 tongue retractor. So what they do when they do intubation is they put this in your anterior oropharynx to pull your tongue forward so that they can fit the tube down there for the intubation. That's pretty sharp. That wasn't designed for a guy with my kind of tori. Now, you can imagine that they come in different sizes. There's, I believe, 5 different widths of these. I'm a larger guy, so they probably said, oh, he's a number 3. But in reality, my small mouth and large tori probably required something smaller. So I think what happened when they put that in, this just sliced the tori, and it created the area of pain. So Dr. Hicks is like, well, there's no nerve left in the tooth. You're not ready for the crown prep. I want to have some fun. So let me do a continuous interlocking suture on your laceration that's so far down it's actually coming out your feet. He did a fabulous job in one of the most difficult areas using, this is 5-0 polypropylene sutures.
Nice job, good Dr. Hicks. Jeez.
Yeah. And he also did this in between patients. I thank everybody for their contributions with this. Dr. Hicks, do you want to recant your comment to me about what if this happened to a patient? The number of times that I've had to revisit this. Could you imagine being a patient and coming back time and time again and nothing is getting resolved? Now, I'm just going to say, I think we're a pretty astute group of doctors that, I don't think we missed the target here. What was your comment about that?
Yeah, just that you have to feel for those types of patients. Again, I think that a lot of us would jump to the conclusion, like yourself, that it was odontogenic in nature. But yeah, I mean, how do you bill for this type of stuff? Someone's just had a major surgery, big hospital bill, and clearly they've needed 4 dental visits. I don't know. It's a tough predicament
right.
to be in.
Yeah, I mean, when you sent that to me, I was happy that you shared that because I think that kind of reflection is something we need to do. I kind of felt like this was better. I mean, he irrigated the area. He induced some bleeding to help get some, a new scar formation because it was exposed. We needed to close it. I went home that night, and after the anesthesia wore off, I was back in the same amount of pain. So I'm like, all right, I'm out of answers. I need to go into literature. I pull up this article. This is an exact article about my problem. Development of osteomyelitis after direct laryngoscopy. All right, so I'm going to skip all this because we only have 10 minutes left. But essentially they're saying less common complications. So they're talking about complications after intubation. Dislocated TMJs is common. We sometimes see patients come in and they have limited range of motion because their lateral pterygoid and medial pterygoids are in spasm. But he says here, less common complications include mucosal tears. Most often, mucosal tears are a result of the trauma from the blade of the laryngoscope, the tip of the endotracheal tube, blah, 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 blah. So here we report adverse sequelae to mucosal lacerations not yet found in the literature. So this was the first article written, and it's the only article that I could find that talked about this. In both cases, there's 2 case reports here. The patients developed osteomyelitis of the mandible after laceration of the overlying oral mucosa after traumatic intubation. I shared this with Regan today, and I'll just get to the point that he made. Osteomyelitis is for old ladies with immunosuppression. This particular patient here did have carcinoma, so obviously he was immunosuppressed to some degree. So one might argue he had osteomyelitis because of it. This is what happened after, and I think this is what we've seen. Libby had the patient within the past 3 months where I think your patient, Dr. Libby, came in maybe several weeks after with that bony island. It's important to remember that this doesn't happen immediately. It's not like they have this occlusal trauma and then 2 days later they have this bony fragment. The pathological process takes time for the bone breakdown to occur to allow this to actually release, and eventually it exfoliates just like a splinter does. But that can take some time. Oftentimes, I've seen it where patients don't have a bony island, but they still have the pain, and I fell into that part of the category. So they did a bone biopsy here, and the only way to diagnose osteomyelitis is with a culture. So I'm reading this, and Dr. Google's always right, so I need to go on antibiotics. And this is where Dr. Regan and I were having a conversation today. I'm going to end with this. This is the end of that paper. Osteomyelitis is inflammation of the medullary portion of bone, but it often progresses to involve the cortical bone and the periosteum. In this case, the periosteum can involve also the mucosa overlying it. Presentation usually involves some signs of inflammation and pain, swelling, trismus. I definitely had a lot of trismus, erythema. I didn't have any exudate, but because it was open, you're not going to see buildup when you have a portal of exit. So I didn't expect to see any exudate. And then over time, you'll have a fragment of bone, which is essentially a sequestrum that will make its way out. So I went to osteomyelitis and I wanted to learn more about it. We don't have time for that. But that's what I am today. So this morning I'm meeting with the management team. We had one of our monthly meetings, and I was talking so much that my tongue kept irritating the beautifully placed sutures that Dr. Hicks put in. And it got to the point I had to go to the office and get them cut out. So I go to the office, I put topical in the area, and Regan wanted to see. And while he was coming over from the other room, he sits down and all of a sudden the suture gave way. And this is what was left over underneath. Anybody want to comment about this? Is this good or bad?
Doesn't look great. looks like the other guys that I've seen. You know, we had to flush them clean. It took several weeks for things to heal out. The one guy, we did have to do a flap thing that Regan helped me with. Regan did it actually, but it's looked like the other two cases that I've seen. We'd either flush it clean, eventually the bone broke off and came through, or we had to pull it out.
So the picture, this looks like bone. This is actually
No, I can tell
soft
that's
tissue.
the bone, but I mean, this looks like what it did before the person got to that point.
Gotcha. So you're saying I'm screwed?
No, I don't know. You're a different person.
Yeah, well.
No, it looks like it's the formation of a bony sequestra. I think a bony little piece is going to pop out of there, or you're going to not get any resolution, and we're going to go back in there, flap the whole thing, smooth out that whole tori, and you're going to feel better within a week.
Well, that would be the hope. I just wanted to talk a little bit. I'm going to come back to that picture. I just wanted to talk about something related / not related. Why do ulcers hurt so bad? Because of time, because it cuts me out in 5 minutes. The reason why certain things hurt in the mouth, certain things being an ulcer, certain things being somebody got a little happy with the electrosurge, has to do with the fact that the epithelium and the lamina propria is removed or gone for some reason, and the submucosa, which contains the nerves, is now the superficial layer. That's when patients are in the most amount of pain. So if you ever decide to use a laser or an electrosurge, keep in mind that you can only go so deep until you expose this, and you really need to know what the gingival biotype of the patient is and take that into account as you move forward. Otherwise, you expose the nerves, which is why a free gingival graft or a connective tissue graft hurts so bad on the palate of the mouth, because what you're left with are exposed nerves. Here's another diagram here. Again, when we do things like gingivectomies, we kind of want to, stay in this area here. It's very hard to tell how thick these components are on a patient, but always remember that when you're doing soft tissue manipulation, that there is a point at which the submucosa gets exposed, and that's when the patient's more likely to be in pain, and you just want to account for that. So that whiteness that we were seeing, I believe, was the fibrin clot. So when I saw that, I was actually happy, because what I think happened, Dr. Hicks went in there. Now, granted, this is the process of a canker sore, but we can draw the same analogy that there was an opening to the submucosal layer. He went in and sutured it, produced some bleeding, which is good, and ultimately I'm seeing the fibrin clot over the top of that. So I feel better. So after the suture was removed, I ultimately felt, this is the best I felt so far, knock on wood, because I've said that pretty much every day so far, but I didn't have any anesthesia today. So this is the first time that I've actually gone to that point. This is a diagram I love referring to for my understanding of how things heal. Time 1 is within seconds to minutes after the injury. Time 2 is minutes to hours. 3 is days, and 4 is weeks to months. As you can see, the fibroblasts start pretty quickly. So this is the fibrin clot that we're seeing overlying the area. So when you see that white area over a lesion, we see this with patients who come back maybe day 2, day 3 after an extraction. It often looks nasty, and that's what we're seeing. We're seeing the fibrin clot. We typically don't see patients at that time frame, but every once in a while when they do come back, if you see that, just let them know that's the first stage of healing. All right, so here's my updated plan. I'd love to hear Regan's take on it. I don't think we're going to have enough time. He doesn't agree with antibiotics. I think he's got a lot of validity to his perspective, but this is what I'm choosing to do. When you're in this much pain, you're okay with taking it. Penicillin and metronidazole. This is called Van Winkelhoff's cocktail. When you think there might be an anaerobic component, you want to add metronidazole. We use these for long-standing infections. I have no doubt this is overkill, but when you're in this much pain, you do what you do. So chlorhexidine, and then if my symptoms don't resolve, I'd say by Wednesday or Thursday, I'm going to schedule an appointment with the oral surgeon. I've reached out to 2 of them. I haven't heard back yet. Ultimate goal, I want to get better so I can enjoy the Bruins in the playoffs. Regan, you got 1 minute. What's your rebuttal?
You're a beautiful doctor. I'm sure you're treating yourself as best as you can. Blinded by all this unbelievable pain.
Yes.
And suffering. Definitely making good choices.
What would you do as the doctor? Oh.